So it's my pleasure really to talk about something that keeps me really busy in my daily work. Here are my disclosures. Obviously, a lot of cooperation with different pharmaceutical companies. And another disclosure, in Germany, we are very lucky that as soon as an agent is approved by the European Medicine Agency, we have immediate reimbursement. So we can use such drugs like CAR T cells or bispecific antibodies very early after approval. And this gives us really a broad access. You see the long list of immunotherapy agents that we can use in Germany. However, ide-cel, as one of the CAR T-cell products, was withdrawn from the market last year because the pricing discussions were not successfully ended. So already one product has left the market. But still, we have a big choice, and this is our current guideline for relapse therapy. You can't even read it. It's full of details, full of options. So it's a very confusing choice that you have to make in every patient. And if we just focus on the left side, you see that we have all the CAR T cells there, the bispecific antibodies, and all the triplets. So we have many things to discuss and to choose from. And it's long discussion with the patients. And so obviously we have to have a very clear idea, what is the potential, what is the role of CAR T cells and bispecific antibodies in myeloma? How can we integrate these agents into the routine therapy? So in our center, we were lucky to have very early access to CAR T cells in myeloma. So we started the commercial programs with ide-cel in end of 2021. And the first patient was really infused on the 3rd of January 2022. And then about a year later, we started with cilta-cel again as one of the first centers in Germany and also in Europe, I must say. And so now we have about one patient a week being treated with cilta-cel. And we also have available all the other commercialized CAR T products in lymphoma. So we are very used to use all these products. And on the bottom, you see our latest kit on the block. We got approval to manufacture a CD19 card designed by the company Miltenyi, but we can produce this in our hospital, in our department, and use this to treat individual patients that have no in-label option for CAR T cells. So this might be a CLL, a Richter's transformation, or also autoimmune patients. So we are very lucky to have this option following the example by Spain that academic production is a very good pathway in addition to commercial CAR T cell products. So this is to show that the acute toxicity that is quite remarkable in lymphoma CAR T cell therapy is not so much of a problem in myeloma. And also to show that between the CAR T cells and the bispecific antibodies, there's not a huge difference in acute toxicity. So cytokine release syndrome is a frequent problem, but for most patients, this is just fever and nothing else. So the more dangerous, severe cytokine release syndrome with blood pressure drop, with hypoxemia, is quite a rare event, and we don't see it much. And similarly, we see very little acute neurotoxicity. And as you see, the numbers are fairly similar between the bispecific antibodies and their step-up dosing phase in the beginning of therapy and in the days following the CAR T cell infusion. So we can talk about a rather safe concept of immunotherapy, no matter whether we choose CAR T or bispecific antibodies as the mode of action. So let's start with a CAR T cell therapy. And it's obviously important to compare a CAR T cell therapy to other standard regimens. And one of the first trials to give us strong, clear results was the KarMMa-3 trial, where we entered 9 patients in this trial. So this was testing a CAR T cell, in this case ide-cel, against a choice of 5 different regimens, and you can see them here. So it was a really broad choice of typical triplet regimens, or KD as a very robust workhorse, I would say, in myeloma therapy. and patients could have 2 to 4 prior therapies, and all patients had exposure to an IMiD, a proteasome inhibitor, and a CD38 antibody. And on the right, you can see that it was really a broad spectrum of prior therapies. Most patients were refractory to at least one of the agents. On the bottom, you can see that 2/3 of patients were refractory to 3 classes of agents. So this was really a kind of hard to treat cohort of patients. And we had a randomization between having a short bridging therapy followed by CAR T-cell therapy or treatment until progression with one of the 5 different mentioned regimens. And you see the blue curves show the CAR T-cell treated patients split into the prior lines of therapy. And as you would expect, if you had only 2 prior lines of therapy, your progression-free survival was better than with more lines of therapy. But no matter how many prior lines you had, it was always strikingly better than in the standard regimen. So the gray curves with the triplet regimens are much inferior, and you see the ranges. You have around 1 year of median progression-free survival with the CAR T-cell therapy, and 3 to 4 months only, I must stress, with the triplet regimens. And if you specifically focus on the triple class refractory, you have to dig in the supplement of the paper, obviously. But hidden here, you find a very important message. If you look at the bottom, the triple class refractory patients, they had 11.2 months progression-free survival with the CAR T-cell therapy, but only 3.5 months with the standard regimen. You see, this is really the population where the CAR T-cell plays out this much higher efficacy. And I would say where triplet therapy is really more or less a bridging concept. You have gained 3 or 4 months of progression-free survival, and then the patient is again in need of further therapy. So a very clear message that for the triple class refractory, you have the biggest medical need for new concepts rather than giving just another triplet regimen. How do the bispecific antibodies compare to this concept? We know we have to do an apheresis for a CAR T-cell. We have to wait for the production. So there's a lot of logistics involved. It's complicated. It's time-consuming. Would it be easier to use just an antibody that you can have in your pharmacy that you can just apply like any other antibody? And looking here at the 3 currently approved antibodies, teclistamab and elranatamab against BCMA, and talquetamab against GPRC5D. Just to have an overview, you see the overall response rates in the area between 60 and 70%. You had a very high number of triple refractory patients in these studies, and you can see on the right that the response rates were really not inferior than to the total cohort if patients were triple refractory. So another option for triple refractory patients without needing the logistics of CAR T-cell. So you can nicely employ bispecific antibodies off the shelf to treat these patients and to bring many of these patients into a remission. But the most important question is always, how long will this last? How long can the patient have benefit from these agents? We don't have any phase 3 trial like the KarMMa-3 trial I just showed you. So many authors have tried to use cohorts of patients from real life, from triplet treated patients, and to match them to study cohorts from the pivotal studies for the bispecific antibodies. So here you have the Majestic trial approving teclistamab, for instance, with a median progression-free survival of 11.3 months. That's the upper curve. So you see the progression-free survival curve is very similar to the one I showed you for ide-cel. So again, also in PFS terms, there is a comparative efficacy between the bispecific against BCMA and ide-cel as a CAR T-cell against BCMA. And also very stable and reassuring, I would say, we see that the median progression-free survival in the control cohort and the real world cohort, no matter if you adjust or leave it unadjusted, you end up in the area of 4 months. So we keep seeing this message. If you try to retreat patients with different triplets, you achieve about 4 months of median progression-free survival. If you switch to an immunotherapy concept, in this case, teclistamab as a BCMA bispecific antibody, you come close to 1 year of progression-free survival. And here the other BCMA-directed bispecific antibody, elranatamab, that's the blue curve. And you see the curves looks very very similar. In red, again, you have a real-world cohort where you again end up in this 3-4 month range of median progression-free survival. And here again, with the bispecific antibody, you can treat a much higher number of patients in a form that they achieve a deeper remission, that they achieve a complete remission. And these patients can really benefit for much longer than over a year sometimes from this therapy. And the third example, you see that the data look very similar. Here is talquetamab as an example for a non-BCMA targeting bispecific antibody. On the left, you have the weekly regimen. On the right, you have the biweekly regimen. And you see that the progression-free survival in the real-world cohort is 4.1 months, again, confirming this very strong evidence that we have. And you see, as particularly with the every 2-week regimen, which is more convenient for the patient, you see a much more stable and prolonged progression-free survival of 14.2 months here in this case. So while we have a lack of phase 3 prospective trials, we can, I think, quite safely say that with the bispecific antibodies, no matter which one we choose, we can dramatically improve the chance of the patient achieving a deep remission and staying in remission for more than the depicted 3 to 4 months with a triplet therapy. There is a new kid on the horizon, another BCMA targeting drug, which has quite a long history. It's the antibody-drug conjugate belantamab mafodotin. It was on the market. We have been using it as a single-agent therapy. It was then withdrawn both in the US and in Europe from the market due to, in the end, not convincing efficacy data. But if you use this agent in combination with other drugs that we are using in routine practice, in this case, it's bortezomib dexamethasone, you see suddenly in patients after at least one prior therapy, a progression-free survival of about 3 years in this case. So in combination, this drug is probably reappearing on the market and will add to the list of options we have when we try to treat patients in first, second relapse with a BCMA targeting agent. But this at the moment is not approved so far, but I think another exciting option to add to our long list of options when we think of targeted therapy against BCMA in myeloma. But now, for me, the most exciting agent in relapse therapy in myeloma is cilta-cel, the other CAR T cell against BCMA. And here again, we have a study comparing the CAR T cell against a standard of care regimen. Here we had dara-pomdex or bortezomib dexamethasone as the 2 comparator regimens. So a POM-based regimen in patients with 2 to 3 prior lines of therapy. And all patients had to be len refractory to be included into the study. So it's a different scenario, only 1 to 3 prior regimens, so 1 line earlier than the KarMMa-3 trial I showed you for ide-cel. And here, patients were not triple-class refractory. They are mostly len refractory or all len refractory. And only a minority of patients, about a quarter, was then refractory to agents like bortezomib or CD38 antibodies. So on the bottom, you see it's about 15% really triple-class refractory. So the refractory status is much lower than I've shown you in the KarMMa-3 trial. And so this leads to a much better performance of the control arm, as you see here in black. But still, if you look at the red curve, the CAR T-cell therapy treated patients, you see after 13 months, only a quarter of patients was still in remission with the statin regimen, which is a remarkable result. But you see that you more than double the chances of the patients being still in remission after 13 months when you give the CAR T cells. So a very clear result that you can have really prolonged remissions with the CAR T cell therapy. And if we think of the further course of the curve, I expect the median PFS to be somewhere between 3 and 4 years. So this is a remarkable new option for the patients in early relapse to again achieve a long-term remission and having also a very good quality of life because the responses are typically very deep. Looking at the hazard ratios and subgroups, you see that there's not much change regarding the hazard ratio in comparison to the different prior therapies. I just want to point out that the triple class refractory are the patients with the biggest benefit in this analysis. You see the hazard ratio is 0.15. So all the hazard ratios are very low, but this is again pointing out that the triple class refractory patients have the biggest medical need. And here, again, the biggest benefit from giving cilta-cel in comparison to the standard of care. And also underlining the importance of using active regimens early in the therapy course of myeloma, you see that here we have already after 3 months of observation, a survival benefit for those patients receiving CAR T cells. So I think we gather a number of arguments that we can really give patients a long-term and even survival benefit when we use the most active regimens in the most early time point. And this was updated from Mariví Mateos at the last EBMT meeting. And also shown at the EBMT meeting earlier this year, we see this very high rate of MRT negative responses. And the response are so deep, so profound, that it doesn't really matter whether you look at the level of 10 to minus 5 or 10 to minus 6. It's really the negativity is not really depending on the level of the assay. You see that really most patients achieved really a very deep molecular response. And on the right, you see it's a very rapid response. So you don't need to wait 2 or 3 years of continuous therapy to have this very deep response like we see in the standard arm, where you have a stepwise improvement of the level of response. With the CAR T cell here, in this case, you see this very early achievement of a deep response. Still, MRD testing is expensive and needs bone marrow sampling. So in our clinical practice, we use something else. We just look at the free light chains 4 weeks after the CAR T cell infusion. A very simple, a very cheap test, and we see usually that the free light chains go to 0. They are not detectable anymore in our routine assays. And this very simple and easy test is highly predictive of a PFS on the left and of overall survival after CAR T cell infusion on the right. So we think we don't in routine practice need the MRD assessment in the bone marrow. For me, it's really the crucial point: is my patient FLC negative after 4 weeks? Do we have a depletion of free light chains? Yes or no? If it is no, then I start to worry, and we should worry early, I would say, and we need new strategies to salvage these patients. And we think of things like EMITs or maybe cell mods in this scenario. The problem is obviously these patients are not progressing at this time point. They just have a suboptimal response, I would call this. And we have no approved therapy for patients with suboptimal response. So this is a problem from the reimbursement side in the end. But I think we have very easy tools to detect early on patients that will likely progress much earlier than we expected. However, most patients achieve a very deep remission, and then it's just the question of seeing the negativity of the free light chain test. Does this work in real world? So since we have been using cilta-cel now for more than 2 years in Germany, we have registry data from the German registry, and we can really confirm that cilta-cel here in the blue curve is giving our patients a really high response rate and a durable response, obviously better than the ide-cel treated patients in red. But I would say still both curves show us a very active CAR T-cell therapy. And these are all useful therapies in myeloma. Looking at toxicity, it was very nicely shown, and I really like this graphical representation. If you look at the lower panels, C and D, you see that the higher CRS grades were really confined to those patients who had still active disease at the time of lymphodepletion. So when we try to reduce the acute toxicity, the best measure we have is to reduce the tumor burden. If patients are in a low tumor burden scenario in CR or VGPR, they have a very high likelihood to have very little or no CRS. And on the right, again, a different look at this. Here is the response conversion coming from a certain response level and then achieving a CR after therapy. And you see that on the right, patient with a CRS grade 3 or 4 were mostly those patients who had less than a PR before the CAR T-cell therapy and then converted to a CR. So this is active, so you can achieve a CR in these patients, but you have to pay the price of CRS, and these would certainly be the patients where we'll have a closer look and maybe not think of things like outpatient therapy or so. How to choose now between all these options? I think we have some clear lines of thinking. It's not black and white, it's gray, but so if patients are then refractory but not CD38 antibody refractory, we can certainly have a choice between carfilzomib-based regimens like Dara-CAD or ISA-CAD, or use cilta-cel. It's in the label, but we have certainly a choice. If patients become triple class exposed or refractory, I certainly would not try to use another triplet agent. I think it's really the call for immunotherapy. So we have the choice between a CAR T-cell based therapy or bispecific antibodies. If patients then become refractory to triple or even 5 classes of agents, then I think all is needed. And we typically use a bispecific antibody between the apheresis and the CAR T-cell therapy, in this case, talquetamab, to avoid cross-reactivity. And so we try to reduce the tumor burden, then give CAR T-cell, and we also use bispecific antibodies after CAR T-cell relapse. And we had some patients where we gave cilta-cel after ide-cel when they had a long benefit from the CAR T-cell therapy. We try to reuse the CAR T-cell concept, and I can tell you at least we see at least the same level of response and response duration in the second CAR T-cell therapy compared to the first one. Again, from the registry, we have data published by Maximilian Merz, and looking at different treatments after CAR T-cell relapse. And you see very clearly, if you're looking at a deep response, a complete remission on the left side in blue, you see this is achievable in a substantial number of patients with talquetamab or teclistamab, but not really with IMiDs. So again, the triplets are not really working that well. And you see this on the right also in terms of duration of response. Durable responses are really only achieved with the bispecifics, not really with triplet combinations. So we have quite a good rationale to tell the patient, now we want to give you CAR T-cell, but then in the follow-up, we have other options to treat you again, and you have good chances of achieving again a complete remission with a subsequent immunotherapy based on bispecific antibodies. So with all these very active agents at hand, can we think of moving these agents to front line? And obviously, we do think a lot about that, and also the studies are going in that way. So just few examples, very early preliminary data. So the Majestic 7 trial is testing teclistamab DR in patients with newly diagnosed myeloma. And just to see in this very early analysis, you have very high response rates. You get 80% complete remissions. And on the right, you see after one cycle, you have a dramatic reduction or even disappearance of tumor burden. So I think combination therapy is an extremely attractive choice. And with all the caveats, very small patient number, short duration of observation, but you get quite striking PFS curves in these early analyses. So this is a very exciting field that we will follow in the future. And there's a lot of thinking of maybe curing myeloma when you see this kind of very early response patterns. Also, if you give CAR T cells, in this case, cilta-cel, in patients after autologous transplantation in first-line therapy, and here it was patients who had no CR after transplant, so a rather negative selection. And again, you had very high response rates and very stable responses. So again, a signal that immunotherapy is a very active addition to frontline therapy. And there are studies underway. In the German study group, we're testing the addition of TEC and talquetamab to the standard induction therapies with Dara-VRd. And I can tell you from our first results, all patients tested were MRD negative, as you would expect with these extremely active regimens. But toxicity needs attention. Obviously, we need to tailor these therapies to make them less toxic. And there's two studies with cilta-cel in first line, one in younger patients testing against transplant and in elderly testing against VRd and RD as standard regimens. So this will be very exciting to see what comes out of these studies. Problem is obviously they are MRD driven and it's accepted for approval as an endpoint, but at least in Germany, MRD is not thought of as an patient relevant endpoint. So we might end up with nice approvals in the European scenario, but then struggling for reimbursement. And at these price levels, we cannot do anything without proper reimbursement. And the other big problem I can foresee in the discussions is what is the correct comparator? So if we can show that cilta-cel is better than VRd, obviously the next question is, how about Dara-VRd or isatuximab-VRd? Can you also show that you're better than these regimens? So it's a difficult field, I would say, maybe not so much for getting approval, but certainly for getting reimbursement. So to sum up, I think we have now excellent results in first-line therapy with quadruplets. And then I think to make patients a nice perspective, we can say we will have CAR T cells available in second or third line as very attractive regimens. And also we have the bispecific antibodies as more easily available and rapidly available agents in these scenarios. We can reassure doctors and patients that CRS and ICANS are there, but usually very mild. And we are working very hard to establish structures for outpatient therapy. So I have treated 5 patients so far outpatient with cilta-cel, and I'm trying to scale up this because I think it's very attractive. And I have at least here a question mark for the role in first-line therapy. Thank you very much.